Cardiogenic shock is what we just began touching on. This is where the pump is not as strong as we want it to be. Okay? This is where the ability to charge the aorta is inherently weak. This can occur from congestive heart failure. The majority of congestive heart failure comes from myocardial infarctions, about 50% of it. The other 50% of heart failure is what we call non-ischemic cardiomyopathy. And that is from viral illnesses, chronic hypertension, familial diseases, genetic predisposition to late development of muscle weakness. Okay? Ventricular aneurysm is a consequence of a myocardial infarction. That's where a wall has already mostly died off, and there's only enough muscle left that it bows out, it just sags out, right? So stress creates congestive heart failure. So you can get something called a Takatsubo Cardiomyopathy if a person is genetically predisposed to have this and they experience an event with a profound exposure to adrenaline, okay? Battlefield shock, unexpected death of a family member. I saw one person have it once because they'd flunked their SATs where they were expecting to completely knock it out of the park, right? If you get this massive adrenaline surge and you're predisposed, you will develop heart failure just from toxicity of that adrenaline on the heart, okay? It has a very characteristic shape on echocardiogram for the majority of those patients. Only the tip of the heart balloons out. It's really weird. It makes a big bulb just going ribbit, ribbit, kind of like a frog's throat, kind of crazy. Takatsubo is Japanese for octopus trap, I think, and that's sort of what it's named after, is the shape of these like round little octopus traps they use in Japan. Stress in the setting of sepsis is also directly toxic to the heart, okay? I am utterly uninterested in hearing that a patient has an EF of 20% as measured by echo 10 minutes after their cardiac arrest. Could not care less. I'd be more impressed if they don't have an EF of 20% right after a cardiac arrest, right? It's like you sleep on your arm. Your arm gonna feel good for the first 5 minutes after you get off it? No! It takes a while for these things to recover, right? So, when you're in sepsis, again, direct toxicity can cause low heart squeeze and requires treatment. There's a reason that dobutamine was real hot for a while in the treatment of sepsis. It's much less prevalent in the algorithms now. Post-cardiac arrest, we just talked about. You stun the heart, it's going to take the heart a little while to recover. Okay, heart failure. This is a useless diagram that doesn't do anything to help you. This is a diagram that just repeats what we've already told you, but it has a very pretty picture over here of a heart that's barely moving. These walls are, I mean, not even discernibly squeezing. That's about as bad as any echocardiogram is ever going to look. I hope your heart never looks like that. If it does, please come see me. We will fix you. All right. Right heart failure is a very special form of heart failure. Listen to me very carefully because you will see this material again. Right heart failure shows all of the signs of congestive heart failure but has clear lungs. Right heart failure shows all of the signs of congestive heart failure but you have clear lungs. So when you're thinking about heart failure, the way to think about it is, where is the problem? Think of it like a highway. There's a wreck somewhere, and the traffic is going to back up behind that wreck, okay? If the left ventricle fails, that's where the wreck is. So what comes before the left ventricle? The left atrium. What comes before the left atrium? The lungs. What comes before the lungs? The right ventricle. So guess what the number one cause of right heart failure is? It's left heart failure. Let me repeat that again. The number one cause of right heart failure is left heart failure. It's just traffic backing up down the interstate, okay? But in right heart failure, the wreck is in the right ventricle. The lungs are down the road. The lungs are nice and clear. Just like the road would be nice and clear if the wreck were here and you're over here. Does that make sense? So, when you see a patient, gentlemen, write this down, with jugular venous distension, chest pain or shortness of breath, lower extremity swelling, and orthopnea, which is an inability to lay down flat without feeling short of breath, Your primary question is, what do the lungs sound like? Okay? If the lungs are wet, you diagnose left heart failure. If the lungs are dry as a bone with no crackles, you diagnose right heart failure. Okay? Why does this matter? Because right heart failure is critically volume dependent. Left heart failure is always volume overload. Okay? So in left heart failure, you're always taking away fluid. Less, less, less. Okay? Got to dry out those lungs. Got to keep those lungs from flooding. Okay? Does that make sense? In right heart failure, you have to be very careful. There's a right amount. If a patient with right heart failure is profoundly hypotensive, you push fluids on them while giving them medicines to flog that right ventricle. That's the D chemicals, dobutamine and dopamine, to get that right ventricle going. All right? So if a patient is having an acute heart attack, it's affecting their right ventricle, they need fluids. The right chamber has become passive. Okay? The right ventricle normally operates at pressures up to 40. The left ventricle normally operates at pressures up to 160. It's not even a comparison, okay? It's like me going to lift with you guys. Different ranks, okay? Same idea. With the right ventricle, it's a weakling. When it becomes passive, you can actually jam enough fluid into the patient to force it through the right ventricle passively and still get some fluid to the lungs and the left ventricle. Okay,